My name is Rain Ellison. Today is July 5th, 2024, and this is my final presentation for my Disease of the Cell project for CellBio. Wilson's disease, an in-depth look into the genetic condition by Rain Ellison. Wilson's disease is a genetic disease that leads to an overabundance of copper in the body. This overabundance of copper can lead to a number of different symptoms. Early stage symptoms are generally liver inflammation related, including vomiting, weakness, ascites, swelling of the legs and abdomen, yellowish skin, i.e. jaundice, and itchiness. Such symptoms can develop within the first decade of an individual's life. Later stage symptoms can be neurological, including tremors, muscle stiffness, difficulty speaking, anxiety, and auditory or visual hallucinations. One of the most notable symptoms of Wilson's disease are Kayser-Fleischer rings, which are a greenish-brown ring around the outer edge of the cornea, as noted in the image on this slide. The only other known condition that leads to Kayser-Fleischer rings is primary biliary chorosis, a chronic autoimmune disease leading to the scarring of the liver's bile ducts. Because this symptom is so specific, it is very helpful in diagnosis. No cure exists for this genetic condition. However, treatment options are available for the 1 in 30,000 individuals impacted. What are the stages of Wilson's disease? There are 4 stages of Wilson's disease. The first stage is an initial accumulation of excess copper within the liver. The second stage involves copper being released into the circulation in an acute level. The third stage is a chronic accumulation of copper into tissue outside the liver, including the brain. The fourth and most advanced stage of Wilson's disease is the need for chelation therapy in order to restore copper balance. Such therapy will be discussed later in this presentation with other treatment options. How is it inherited and how do we diagnose? Wilson's disease is an autosomal recessive disease, meaning that the genetic mutation itself is recessive and inherited only when both parents have the mutation. Should only one parent have the mutation, the child may have the mutation as well and could pass it on to their children, but will not themselves develop the disease, meaning carriers do not present with the disease itself. Based on genetic inheritance predictions, children whose both parents are carriers have a 25% chance of developing the disease. Symptoms can be developed as early as 5 years old or up to and into your 40s. Genetic testing of specific locations of the genome is possible to confirm diagnosis. However, since symptoms are so specific, diagnosis is possible without testing. Since it is possible to present itself throughout an individual's life, Wilson's disease can be diagnosed at any stage in life. Diagnosis occurs through a systematic evaluation of signs and symptoms, especially of KF rings around the cornea, and some more specified testing. Such specific testing includes ceruloplasmin lab level draws and a urinalysis for copper levels in the urine. If the individual who has Wilson's disease has their ceruloplasmin lab drawn, there will be a finding of less than 20 milligrams per deciliter, abnormally low. and their urinalysis will have a copper level of more than 100 milligrams per deciliter, which is abnormally high. Once again, the ceruloplasmin will be abnormally low, and the copper levels of the urine will be abnormally high. Once an individual has been diagnosed with Wilson's disease, preceding family members, meaning offspring or siblings, may consider testing to see if they are carriers. What happened? Wilson's disease, in genetic terms, is caused by a mutation of the ATP7B gene associated with the coding of the ATP7B protein used in the absorption and excretion of copper pathway. Over 800 mutations have been reported. However, they are most commonly seen as small deletions, missenses, or splice junction mutations. Additionally, mutations are most frequently located in the central region of the gene, although may be located in other loci along the gene. In the copper pathway, ATP7A regulates the uptake of copper into the bloodstream from the small intestines. Within the small intestines, copper is then transferred to the liver. Within the liver, ATP7B mediates the excretion by transporting copper to bile. With a mutation of ATP7B, copper cannot be excreted from the body, and a buildup of copper in the liver can occur. This can lead to an acute inflammation of the liver. Furthermore, the overflow of copper can enter the bloodstream and subsequently affect other organs, especially in the brain. The copper abundance on a molecular level can lead to the oxidation of lipids and proteins. As you can see on the image of this slide, there is liver tissue with an abundance of copper, the small red marks. Because the abundance of copper in Wilson's disease is caused by the genetic mutation of copper absorption excretion pathway, there's no cure for the disease. However, treatment is available. How do we treat it? As said, there is no cure for Wilson's disease, nor is there prevention, as it is genetic, but there are treatment options. Treatment may be in one of two forms: copper chelators or zincs and salts. A combination of the two is also possible. The copper chelators will bind with copper in the blood and help facilitate excretion. This is often a more extreme form of treatment. The zincs or salts will interfere with the uptake of copper in the small intestines, thus leading to less copper in the bloodstream. Individuals should also monitor their copper intake on a dietary level. Foods such as mushrooms, chocolate, shellfish, liver, nuts, and dried fruit should be avoided as they have higher copper levels than other foods. Tap water testing may also be beneficial, and treatment of tap water may be encouraged. These treatments, along with a low copper diet, can help mitigate the disease throughout an individual's life. As with all aspects of medicine, there is no universal standard for the duration or intensity of treatment. However, healthcare professionals will provide patients with a care plan that is fit for them. And once again, cures do not exist for this. Treatment will be lifelong. Wilson's disease can present itself in concurrence with other diseases. However, it does not appear that any other diseases would lead to Wilson's. Rather, the opposite may occur. Later stage untreated Wilson's disease may lead to neurological effects. Such effects have been associated with diseases such as Alzheimer's and Parkinson's. Additionally, there has been a recorded link between liver copper and iron biochemistry. Ceruloplasmin, a copper-carrying enzyme, is also used in the iron oxidation and transport pathway. In individuals with Wilson's disease, the ceruloplasmin lacks the cofactor needed for the pathway to flow productively, which is why their lab draw will show an abnormally low result. This then leads to a lower level of circulating iron and a higher level of iron accumulated in the liver and organs, which will also have a negative impact on the individual's liver. Many of the impacts of the Wilson's disease may ultimately lead to the need for a liver transplant in order to improve quality of life and prevent liver failure and possible death. With 1 in 30,000 individuals impacted by liver disease, its future outlook bodes promising. Quality of life research is being conducted regarding neurological effects of Wilson's disease. In a certain French study, liver transplants had a positive impact on improving neurological effects when medical treatments had failed. Furthermore, gene therapy may be on the horizon, but is not yet an option for treatment. These are my references used for my disease of the cell presentation. Thank you.